This is EHJ Today. I'm Tom Lüscher, Editor-in-Chief of the European Heart Journal, and I'm sitting here in Davos at the Cardiology Update, and we will speak with Professor Stefan Windecker from the Heart Center in Bern. Welcome, Stefan.
Good morning.
So we will discuss the guidelines of the ESC, and you have been the chairman of it. And of course, these guidelines have appeared over the years in regular intervals. What was the reason to update the guidelines this time?
Thank you, Tom. I think it was an important opportunity actually for the second time to produce this joint guideline between the European Society of Cardiology and the European Association of Cardiothoracic Surgery, which actually was published for the first time together with William Wines and Philip Cole in 2010. Now, in the meantime, during the past 4 years, there has been important progress both in the area of interventional cardiology, namely advances with new generation drug-eluting stents, but also with coronary artery bypass surgery. Just as one example, the final 5-year results of the SYNTAX trial had been published, and these importantly influenced and informed the guidelines. And as such, for this second joint effort of the guidelines, actually the group also performed a systematic review of the entire evidence in the field of revascularization, which was published independently together with the guidelines in the British Medical Journal.
Right. So can we summarize the most important take-home messages of the new guidelines for our viewers?
I think I would like to highlight 3 areas. The first area is that of the indication of revascularization. And here there has not been a major change, but an important maintenance. What are the principal indications for revascularization, either PCI or coronary artery bypass surgery? And the first one is for symptomatic reasons, despite medical therapy, that patients continue to have symptoms of angina. And there, revascularization assumes a class 1 indication. The second important one is for prognostic reasons, and that is patients with important lesions in the left main coronary artery, in the proximal left anterior descending artery, patients with advanced coronary artery disease, and those with extensive ischemia. Also there, revascularization remains a class 1 indication. The second important update has been regarding the use and type of stents. And there we recognize that there have been major advances, particularly with the new generation drug-eluting stents. And a major change at variance with the previous guideline is that we recommend now new generation drug-eluting stent in all patients in all clinical settings, including stable coronary artery disease, including patients with non-ST elevation myocardial infarction, including patients with ST elevation myocardial infarction, and also patients requiring triple antithrombotic therapy in the setting of atrial fibrillation. Now, the third important topic, which is important for practitioners and readers, relates to the relative indication of PCI versus coronary artery bypass surgery. And there have been also important changes, and those relate once to the indication of proximal left anterior descending artery stenosis, both in patients with 1 vessel disease and 2 vessel disease, where now newly PCI assumes the same indication and class 1 indication as coronary artery bypass surgery. The second one relates to patients with 3 vessel disease, and there also has been an upgrade in those patients with simple 3 vessel disease defined as a SYNTAX score as less than 22, where also PCI assumes a similar class of indication in class 1 as coronary artery bypass surgery. Conversely, in patients with advanced coronary artery disease, SYNTAX score more, it is relatively contraindicated. And finally, in patients with left main disease, again, in those patients with simple left main disease and SYNTAX score of less than 22, PCI assumes now a class 1 indication, similar to coronary artery bypass surgery, whereas in patients with advanced left main disease and a SYNTAX score of more than 32, surgery is the therapy of choice.
Left main is now a PCI indication. That actually is surprising for experienced physicians. How did this change?
I think there has been an important dichotomy in the disease extent of left main disease, and that relates to ostial and shaft lesions, which are actually very focal and can be easily treated by percutaneous coronary intervention. Conversely, we have to recognize that still the majority of left main lesions are distal left main lesions involving the bifurcation and frequently are associated with advanced coronary artery disease, and for technical reasons, PCI probably remains inferior as compared to coronary artery bypass surgery.
Right, so it's very important whether the bifurcation is involved or not. Now, for practice in cardiology, it's very important to know what do we do after. And that, of course, recently has been quite a discussion with several publications with not quite the same results. What did you say in the guidelines, and how do you see it now?
Yes, I think you refer mainly to the important topic of antiplatelet therapy after either PCI or coronary artery bypass surgery. Now, when the guidelines were published, we were not aware of the results of the DAPT trial. Nevertheless, the guidelines emphasize heavily an individualized approach in patients with stable coronary artery disease. What we recommend in general is that in patients with uncomplicated stable coronary artery disease after PCI, a routine regimen of 6 months of dual antiplatelet therapy is advised. However, we also recommend that, for example, in patients at high bleeding risk, so very elderly patients who have had previous episodes of bleeding, even shorter durations of dual antiplatelet therapy after drug-eluting stents can be considered.
Like 3 months?
Like 3 months, even shorter, potentially 1 month on a very individual basis. There are actually data which are observational, not randomized, that as early after 1 month the risk levels off after new generation drug-eluting stents. However, we also emphasize that in patients with very high ischemic risk and low bleeding risk, longer durations of dual antiplatelet therapy can be considered. And I think these recommendations were wise in the context of the recently published DAPT trial. One has to recognize that the DAPT trial has been performed particularly in a US environment. They did include new generation drug-eluting stent, one type, but only in less than 50% of patients. And also patients were randomized only after 1 year, being event-free for both ischemic events and bleeding events. And actually the ESC has now convened a new task force to actually discuss the implications of the DAPT trial and other trials to come forward for long-term dual antiplatelet therapy against the background of previous guidelines, and we will see what these new task force come up on recommendations.
But with ACS patients, you would still go for 1 year?
Yes. So in ACS patients, there has been no change, and that maintains a duration up to 1 year. But I think here the important discussion will be whether we are able to identify patients who are at continued risk beyond 1 year and maybe may benefit from long-term therapy. There are several ongoing trials investigating either dual antiplatelet therapy with more potent P2Y12 inhibitors. There are also trials ongoing investigating the single use of potent P2Y12 inhibitors without aspirin. But I think this we can conclusively answer only in the future.
All right. Thank you very much, Stefan.
Thank you, Tom.